Great. Okay. Well, we'll get started now. I'm Ben Harder with U.S. News and World Report, and I want to welcome you, and thank you for staying after the official conclusion of HOT for this first-time workshop that we're holding this year on creating a new hospital ranking. Can health equity be measured? So I'm here today because of the feedback that we have gotten from healthcare providers over the years, and also because of the internal conversations that we at U.S. News have been having about the importance of measuring what health systems do beyond their walls to advance the health and all of the aspects of the equity of providing equitable care to the populations that they touch. And so I want to welcome our esteemed panel here. I'll just introduce folks briefly and then turn it over to my colleagues who have been working hard on several important data sets and have some preliminary findings that they'd like to share with you. I just want to say one thing. This is very much at the ideation stage. We are beginning a journey that we think is going to lead all of us to a very important place in advancing health equity and understanding variations in those aspects of health. But this is not the introduction of a new methodology or a new ranking that you're going to see by December 31st. So I just want to be clear, or any other specific time in the future. So just want to introduce first two of my colleagues who have been doing this work, and we'll speak in a moment. First is Greta Martin, who's a health data scientist with U.S. News and World Report, and to her left and your right is Anwisha Majumdar, also a health data scientist with U.S. News. The two of them are our principal investigators, both on the measures of acute care that we publish as the Best Hospitals rankings, and they've also been spearheading this team effort that we have undertaken to look at health equity. We're also joined today, and we'll hear remarks from a number of thought leaders in this arena. First, we'll after Greta and Anwisha present, we'll hear from David Narrance. Dr. Narrance is the Director Emeritus of the Center of Health Policy and Health Services Research at the Henry Ford Health System, and he's also the Vice Chair for Research in the Department of Neurosurgery at the Henry Ford Medical Group. Dr. Narrance has also done, as many of you know, some really important multi-stakeholder work on measuring social determinants and understanding how those factors play into hospital performance. So look forward to hearing from him. Second, we will hear from Dr. G. Bai, who is, Dr. Bai is the Associate Professor of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health, and has done some research that's very relevant to some of the work that we've begun to do here. Our third sort of discussant will be Dr. Ram Raju, who is Senior Vice President and Community Health Investment Officer at Northwell Health. And then batting cleanup will be Dr. Stephen Lockhart, who is both a physician and a PhD, and is the Chief Medical Officer at Sutter Health in California. So without further ado, I'm going to turn it over to Greta to share her work.
Thank you for being here today. In today's session, we're going to walk through our new proposed research question and 3 descriptive analyses using different data sources. As Ben said, none of these analyses are intended to be the be-all, end-all, and we have no timeline for releasing a ranking. Rather, this session and the descriptives that we will present are intended to encourage discussion about how we might begin evaluating hospitals on their contribution to health equity and to highlight some of the complexities and challenges of that measurement. We will then invite our panelists to respond and then open up the floor to all of you to answer your questions. For the past 30 years, the research question behind our rankings and ratings has been which hospitals provide the best quality of care in a given procedure, condition, or specialty. But there are a lot of ways to define a hospital as best. We believe that it is important to consider not only the quality of care that a hospital provides, but also who is benefiting from that care. We'd like to begin evaluating hospitals on their contribution to health and health equity in the communities they serve. So what is health equity? In a completely equitable world, we would not see health disparities across subsegments of the population. where those group definitions have nothing to do with health. So while we'd still expect to see older people to be sicker and women to live longer, we wouldn't expect to see differences in high blood pressure rates across racial lines or strong geographic patterns of opioid addiction. Given its multidimensional nature, there are a lot of ways we could approach evaluating hospitals on their contribution to health equity. Do we mean racial equity, socioeconomic equity, equity for patients once they've reached a hospital's walls, or equity in access to that care? Are we talking about equity of purely clinical care or other things that we know to be critical to health, like safe housing, healthy food, employment, and transportation? For these analyses, we have considered health equity across several of these dimensions with our new proposed research question in mind. How do hospitals contribute or not to promoting health equity in their communities? While there are many institutions and players that are responsible for health equity, we have chosen to focus on hospitals for a few reasons. One is because we've been measuring hospital quality of care for 30 years and have grown a large audience in that space. Secondly, as hospitals continue to morph into systems with ever-expanding reach, they have increasing influence over the health of their communities and who is able to benefit from their services. And lastly, hospitals themselves view their own purpose for being not only to provide excellent care, but also to improve the health of the communities they serve. This can be seen in the following selection of mission statements taken from our honor roll hospitals list. Before we walk you through the descriptive analyses we've done, we want to orient you to our conceptual framework for health equity. On the left-hand side, in blue, we have socio-ecological factors, discriminatory beliefs, and institutional power interact to create social inequities, or what we often talk about as social determinants of health. Things like access to transportation, employment, housing, and many neighborhood factors that are incredibly predictive of health. These social determinants play a big role in the right-hand side of the framework, shown in green, a more typical medical model of health, where health behaviors and risk factors manifest in disease and injury and ultimately impact health outcomes, leading to morbidity or quality of life and mortality or life expectancy. While our existing healthiest communities rankings consider many elements of this framework to evaluate the health status of the community, for this analysis, we will focus on the hospital and the way in which it interacts with its community. So how can hospitals make an impact on health equity? There are several pathways that we see. First, through programs and investments that address social determinants of health. Second, by addressing barriers to accessing high-quality, non-emergent care. And third, once a patient arrives at a hospital, by eliminating gaps in health outcomes that are the result of provider biases, such as differential referral patterns or treatment plans. For this presentation, we have used 3 different data sources to look at how hospitals are contributing to health equity through disparities in patient outcomes, financial decision-making, and their management of ambulatory care-sensitive conditions in their communities. What we were able to measure is in part a reflection of health equity. With Medicare being the only nationally equivalent data set of claims information, maternal and child health care are a glaring gap in this look at health equity. So we will start with a descriptive analysis of disparities within a hospital in risk of mortality and readmission by patient race and socioeconomic status. We will then take a look at Schedule H data on community benefit spending of nonprofit hospitals, and finally look at data on access to non-emergent care within a hospital service area. So going back to our conceptual framework, we see these 3 approaches as potential proxies for thinking about the 3 pathways that we've outlined of a hospital's influence on health equity: investments in social determinants of health, access to non-emergent care, and provider bias. In its most narrow conception, our research question would evaluate equity within the walls of a hospital and consider the rest to be beyond a hospital's control. For this first approach, we looked at inpatient Medicare fee-for-service claims to evaluate within hospital differences in health outcomes by race and socioeconomic status. So the same data that we use for the procedures and conditions and specialties ratings, looking at within hospital differences. For the purposes of this analysis, we looked just at differences between white and black patients and used dual eligibility as, for Medicaid and Medicare as a proxy for SES. And I'll talk about race and SES throughout this analysis, but going back to our conceptual framework, we're really talking about discriminatory beliefs and institutional power that result in differences in risk for certain patients. So in this graph, we can see the average within hospital disparity between white and black patients on risk-adjusted mortality. In very low mortality procedures like hip and knee replacement, you can get this pointer to work, you can see that the difference is almost none and that there's relatively no mortality. But in heart surgery and medical cohorts, we can see a difference in risk of mortality. Black patients have a lower risk of mortality in the medical cohorts of heart failure and chronic obstructive pulmonary disease, and a higher risk of mortality in heart bypass and aortic valve surgery than similar white patients. This is the same graph, but now the dots are represent whether a patient was dually eligible in Medicare and Medicaid or not. And you can see similar patterns where there's a gap in mortality by SES that's harmful for dual eligibles in all cohorts but heart failure and COPD. This next slide shows the spread of that within hospital disparity in mortality. This graph looks at race, and the next one will be at dual eligibility. So each dot on this graph represents a hospital that is an outlier in outcome disparities, while the center boxes show the middle 50% of hospitals. So the majority of hospitals lie very close to zero or no difference in outcomes by race. However, there's a large spread with lots of outliers, and most of those outliers fall on the side of outcomes being worse for black patients. So this is now that same graph, but looking at dual eligible status. And you can see very similar trends where most hospitals are clustered around zero, but there's a wide range and more outliers on the left-hand side of the graph, meaning that dual eligible patients have worse outcomes than non-dual eligible patients with similar comorbidities at those hospitals. We also looked at readmission as an outcome of interest. And across all 9 cohorts, black patients had a higher risk of readmission than white patients with similar comorbidities. The same is true of dual eligibles, that their risk of readmission is higher than non-dual eligibles across all 9 procedures and conditions. We were curious to see how performance on these 2 outcome measures, which factor into many of our procedures and conditions ratings, aligned with within hospital disparities. In these 2 graphs, we looked at the risk difference between dual eligibles and non-dual eligibles in death on the left-hand side and readmission on the right-hand side by outcome performance tier. So we're now just looking at the COPD cohort. And as you can see, as a function of that outcome performance, the risk of mortality and readmission goes down as we move across the graph from below average to excellent hospitals on that outcome. However, the disparity, or the gap between the purple and yellow dots, is pretty stable across all 5 performance tiers. The pattern that we saw in the earlier graphs of dual eligibles having lower risk of mortality in the medical cohorts and higher risk of readmission is very clear in these graphs and is consistent across performance tiers. While in some ways this approach of looking at within hospital disparities is ideal because we can confidently say that a hospital is responsible for treating patients the same who have similar risk profiles and come in for the same procedure, it misses where most of inequities happen outside of the hospital's walls. We can get a glimpse of that in the mortality graph, where things like access are likely muddling this picture. If dual eligible patients are less likely to have their conditions covered on a non-emergent outpatient basis, then it's possible what we're seeing here is that they're having their conditions managed through repeated admissions to an inpatient setting. And we'll come back to that in our third analysis.
So moving on to our second descriptive analysis, here we are still within a hospital's walls, but shifting from clinical outcomes to hospital spending as a proxy for priorities. Most hospitals in the country are nonprofits, and in exchange for their tax-exempt status, they're supposed to provide a certain amount of benefit to their community. This was most recently codified in the Affordable Care Act, but there is no guidance provided on how much community benefit a hospital is required to provide or what kinds. And there are studies that suggest that only 2/3 of hospitals are providing enough community benefit to make up for their tax exemption. In addition to the IRS Form 990 that details basic nonprofit information such as revenue and payments, hospitals also fill out a Schedule H form specifically for hospitals that details community benefit activities. This Schedule H form has community benefit broken down into 8 subcomponents, which are all shown here. So this pie graph breaks down overall community benefit spending into those subcomponents and shows what percentage of the total community benefit went into each bucket. It's worth noting that community health improvement is the second smallest bucket here, showing that hospitals still mostly see their roles inside their walls. 2 of the largest subcomponents, unfunded research and health professionals education, do not provide direct patient benefits and are things that a hospital gets some payment for already, with the unfunded amount being claimed as community benefit. If these things have a benefit to the community, they're most likely downstream and indirect. Unfunded Medicaid, charity care, and subsidized health services are considered direct patient benefit. Charity care is free or discounted health services for those who meet an organization's criteria for financial assistance and does not include bad debt. This is also the piece that is most traditionally considered community benefit by hospitals. Subsidized health services are clinical services that if a hospital did not provide, the service would be unavailable in the community or become the responsibility of the government or another tax-exempt organization. The Medicaid piece, which you all can see is far and away the largest piece here, is the shortfall that hospitals claim between what it costs to treat Medicaid patients and what they are reimbursed by Medicaid. It should be noted that all of these pieces are beholden to what hospitals say are the costs of treating these patients. In some cases, we've heard that hospitals use different benchmarks than what the IRS recommends or what most hospitals choose to use, though most are truly treating this as at cost. Looking across all hospitals, we wanted to look at how much hospitals were claiming on community benefit compared to their total revenue. So we see a distribution here with a median around 21% and the middle 50% of hospitals between 14 and 29%. To get a better understanding of what's driving the differences, we wanted to take a deeper dive into the top and bottom quartiles of this community benefit to revenue ratio, so these 2 red boxes. The top and bottom quartiles spend drastically different amounts on community benefit, both as a ratio to total revenue and dollar amounts. We can see about a 4-fold difference in percentages and in total dollar amounts between the bottom 25% and the top 25%. On certain structural characteristics, these groups are very similar. For example, the hospitals in both groups are mostly urban and have roughly the same number of beds. However, we see a lot more children's hospitals and teaching hospitals in this top quartile, and which makes sense as these hospitals often have explicit community health missions. We also see a higher percentage of dual eligible patients as ascertained from inpatient Medicare claims in the top quartile, and also more of those hospitals are in Medicaid expansion states. Breaking down this community benefit a bit more for these 2 groups, we looked at each of the subcomponents as compared to total revenue. As you can see, hospitals in the top quartile, shown by the blue bars, are spending more as a proportion of their total revenue on every subcomponent. This is great for the direct patient care components, but they are also spending more on health professional education and unfunded research. It's also worth noting, again, that very little money is going to community health improvement. It's so small you kind of can't even see the bars up here. Zeroing in on the charity care at cost piece, which is often thought as one of the areas that hospitals have the most discretion, it is worth noting that if the hospitals in the bottom quartile raised this ratio to that of the top quartile hospitals, that would add another $18 billion in charity care across those 770 hospitals. We've all seen the stories that Ben mentioned in his keynote about patients being sued for inability to pay their hospital bills, and more money for financial assistance could be life-changing for those patients. Staying on the theme of charity care at cost, we also wanted to compare this number directly to the single highest paid executive at each hospital as a proxy for priorities. These medians show that hospitals are spending more on charity care than their single highest paid executive, which is good, but for the bottom quartile, it's less than a 2-to-1 ratio, and for the top, it's about 3-to-1. When considering that charity care should encompass hundreds, if not thousands of patients, this ratio seems a bit lopsided. Additionally, about 30% of these nonprofit hospitals, whose mission is to serve the community, spend less on charity care than their single highest paid executive. The overall message we see from this analysis is that hospitals have a lot of choice and leeway in terms of where they put their money and whether or not they use that money to advance community health. And our last piece is moving outside of hospitals' walls, getting at the question that I think we ultimately want to answer, which is how are hospitals advancing community health? And for this, we're looking within access. So many of you might know this map. These are Dartmouth Atlas hospital service areas, of which there are about 3,500 in the country. These are natural markets for normal healthcare, defined on the basis of travel for common causes of hospitalization. So where you would go for routine care, not where you would go if you needed a very specific brain surgery. And we wanted to look at ambulatory care sensitive condition discharges, which are often a common proxy for how a hospital or how an area is doing at managing conditions such as COPD, asthma, diabetes, that can be managed effectively on an outpatient basis, but are, if not managed properly, then result in inpatient admissions. So looking at ambulatory care sensitive condition discharges per 1,000 Medicare beneficiaries, we see across the board a general decline in these inpatient admissions from 2010 through 2015, which is good. That's what we would want. That means that people are managing their conditions on an outpatient basis. However, if you look at the difference between white and black patients, we see a persistent disparity, one that seems to be narrowing as we go further in time, but exists nonetheless. And addressing this gap would have resulted in 45,000 fewer admissions nationally for ambulatory care sensitive conditions in 2015. 45,000 might be a drop in the bucket compared to the total number of Medicare hospitalizations nationally every year, but it is very meaningful for those 45,000 patients. We also wanted to look a little bit broader at census divisions on where hospitals or regions were doing a better job of managing these ambulatory care sensitive conditions and where hospitals were doing not such a great job. So the mountain region deserves accolades. 90% of their hospital service areas improved the gap between white and black patients on ambulatory care sensitive conditions in this time. However, the Pacific, West, North Central, and Middle Atlantic were areas where fewer than half of all hospital service areas improved their disparity in that time. And I think, again, this speaks to choice and priorities, though we do recognize with this analysis that there are aspects outside of a hospital's control that can lead to these, to doing a better job on these disparities or not. So for example, perhaps the mountain region has a lot of really fabulous NGOs that are working on getting patients the care they need. And that might explain why they narrowed their disparities as opposed to things that the hospitals were doing. So looking across all of the three approaches we talked about today, we recognize that they all have strengths and weaknesses, and sometimes a strength for one is a weakness for another. Starting with the disparities in health outcomes that Greta presented, this is the closest to our mission of patient decision support and it's very attributable to hospitals. It's coming from Medicare claims. That's where we do all of our quality analysis, so that makes sense. But as Greta mentioned as well, it doesn't account for access, and there are often sample size considerations once you're getting into smaller subgroups. For the community benefit investment, it has the potential to impact social determinants of health, which we've heard from many of you and from several sessions at this conference. People are really starting to care about and think about. And it is at a hospital's discretion, or at least parts of it. However, we recognize that there are comparability and validity issues of community benefit dollars. $1 spent on a one-day health fair doesn't really improve the health of the community as much as $1 spent on access to fresh fruits and vegetables. And we do know that there are issues with tax ID to AHA ID, or Medicare provider number conversions. And lastly, the access to non-emergent care. It gets at what we believe to be a hospital's ultimate mission. But as I said, there's an issue with attribution of community factors to hospitals. So as we move towards a new ranking, it's important to emphasize that anything we eventually publish as a ranking won't just be one of these pieces. Ultimately, whatever we develop will likely draw on several ideas as a composite measure and would probably involve multiple different data sources and spheres of influence. We know that what we've presented today doesn't address maternal and child health or behavioral health, which we know are very important areas of equity. And most importantly, we understand that this is a complex space and it will be impossible to measure all aspects of health equity that matter. That said, it is an area of healthcare delivery that we cannot continue to ignore. You can't improve what you don't measure. With that, I'm going to move on to our esteemed panelists to give us their take on what we've done here and their previous work in health equity spaces. And we're going to start with Dr. Nair.
Well, thanks very much. Thanks to U.S. News for taking up this important issue and having us all here today. Thanks to all of you for taking time out of your day, especially after the formal close of the conference, to attend to this and share the discussion. The title here mentions a few cautionary thoughts, and I just need a couple of minutes of preface here. I share the strong focus on the importance of health equity as an issue, the importance of measurement, but I do have some concerns about some of the details of how this might roll out, so I'll preface my remarks by saying we're going to go a little bit in that direction. First disclaimer, these are my own thoughts. I'm not speaking on behalf of any organization, not my employer, not any other that I'm affiliated with, so that's the first disclaimer, just in case I make anybody mad. And then second disclaimer, there was a nice picture of me 2 slides ago. This is a picture of me too, in a figurative sense. I've been accused, and I don't deny it, that I'm a little old-fashioned and traditional in my views of quality of care, quality measurement, accountability, those sort of things. So keep that in mind as I go forward here. I do have some concerns about the conceptual foundation that we have, particularly the issue of holding hospitals specifically accountable for all these domains of measurement. I'm most comfortable when we hold hospitals accountable for the things that they do, the things that they have control over, and I'm generally fine with holding hospitals accountable for equity concepts and measures within that domain. But as we move out, particularly we get out into the domain of public and community health, I get less comfortable, and I'll explain that in the next couple of minutes. When hospitals have in their mission statements that they're going to improve the health of the community, we have to think a little bit about how literally should we take that? Is that a formal, literal claim, or is it a marketing slogan? Is it a trade puff? And I just caution everyone to acknowledge that in some cases it's the latter. Not that it's a lie, not that it's evil in any way, but it's an aspirational statement. It's broad, it's designed to sort of motivate the organization to think in the broadest possible way, but not necessarily to be taken literally in the full broad sense that the words might imply. And it's, there's a long tradition of this, and I just caution folks that when you see these words, be careful about what it means. Now, again, I don't blame hospitals for using this kind of language, because hospitals do improve the health of the community. They have always improved the health of the community, at least since they've had technologies that are effective and really do improve health and save lives. But they do it through the ways, at least in my taste, that they have done it for a long time. By taking care of really sick people who need highly specialized services by trained individuals who have unique skills that no other entity in the community has. If you have a serious illness, you have a serious injury, even they're life-saving screening things like colonoscopies that cannot be done elsewhere. They're done by hospitals, and to me that is sort of the essence of the community benefit of a hospital. So if we sort of keep the accountability in this domain, I'm generally pretty comfortable. It's when we reach outside, particularly when there are other entities who might be even better suited to do it, that I feel a little better. Just to focus for a second on the ambulatory care sensitive conditions. If we look over on the left here, this is just a reminder to us. This is directly taken from the AHRQ sort of technical description of this measure. This happens to be asthma, but it's a whole set of measures. Is not a measure of hospital quality. This is the current state that we have. This is according to the official sort of steward and holder of the measure. Now, this whole session is about the future. Okay, I get that. We could move to a state for which this statement does not apply and say, well, actually, we wish to create all the circumstances under which this is a measure of hospital quality. But now I caution, and we go over here, a little semantic apology, I mentioned future state. The graph here is actually 10 years old, but I'm going to make a point here in just a second. The balance of spending, national spending 10 years ago, hospitals, this big slice here, public health is this little bitty red space here. The ratio is 10 to 1. If we move to a direction that says hospitals are going to be accountable for more and more things than they are now, I think the big slice is going to get bigger. The little slice is going to get smaller. And the question to all of us is that the scenario that we would wish to have? I have my concerns about that. And if we don't move in a direction where there are distinct new funding streams to expand this role, particularly out in the domain of community health, why do I worry about this? It's the concept of time and opportunity cost, that at least with current funding streams we have, or even slightly modified ones, there's only so much in any given day that hospitals can do. There's only so much that hospital leaders can pay attention to. There's only so much they can manage actively. And an hour spent doing one thing is an hour not spent doing something else. And $1 spent doing one thing is $1 spent not doing something else. And having spent a whole lot of time around hospitals and in hospitals, it seems to me that there are really crucially important things that have not yet been perfected in hospitals. Infection control, better functional outcomes for patient, better patient experience. And we have to decide, are those things now clearly less important than some of the broad community health outreach things? Maybe yes, maybe no. I'll look forward to the discussion as we go forward in this session. But I have some concerns about that. So, do I think health equity is a really important concept? Yes, I do. I've been working in that area for quite a long time. Do I think there are measures that we should pay attention to keep a focus on that and derive some sort of accountability? Yes, I believe that. Do I think that there are entities for which there can be some accountability for that? Yes, I think that's true. Are those entities hospitals? I'm not so sure about that. But I'll enjoy the discussion. Maybe I'm wrong.
Thank you, everyone. I'm Ji Bai. I'm from Johns Hopkins. I'm a CPA. I teach at Carey Business School at Johns Hopkins. I'm also joint appointed at the School of Public Health. I study hospital behavior. It's my great pleasure to be here today with you, and thank you very much for having me. Overall, to measure equity for hospitals is a great initiative because we are going beyond the traditional performance measures. So traditionally, we say hospitals doing great, if you are delivering good care to patients, you are billing insurance companies appropriately and paying your employees and paying your creditors on time and maximizing your shareholders' wealth if you are for-profit, or if you are being accountable to taxpayers, if you are nonprofit, right, you enjoy tax-exempt status, or if you're a public hospital, you are funded by tax revenue. As long as you do these things, you're good. But now the US News starting this initiative saying, let's go beyond that. Let's look at hospitals' accountability to their social and ecological community. So this is a great advancement. Now let me put on a content hat to look at this from a theoretical perspective. In accounting and economics, we say a performance measure is good only if two conditions are met. By the way, accounting is about counting beans. Performance measurement is really in our domain. So the two attributes, number one, high congruence. Are we measuring the right thing? So we are looking at the superficial performance measures. Are they reflecting the underlying construct we care about? Second, high sensitivity. So are the metrics sensitive to a hospital's action? So in other words, are those things within hospital's control or not? If we have low congruence, then the problem is hospital might game the system and distort action. Let's say we're going to measure how fast you charge patients. That's a distorted performance measure because hospitals can discharge patients quickly without adequately treating them, right? Low sensitivity will put unnecessary risk on hospital's shoulder, which is suboptimal. And the hospital is not getting compensated. On the market, yes, if you are bearing risk, you get compensated, high risk, high return. But in this case, hospital is not being compensated, so it's suboptimal. So for example, let's say we measure the local community rate of car accident, and we ask hospitals to be accountable for that. That is called low sensitivity, right? Because the car accident rate in the local community is kind of out of control of the hospital. So two attributes, high congruence and high sensitivity. Now let's look at the commonly used community benefits measures from 1990. Okay, this is the most commonly used available metrics we can rely on. So this is just a snapshot from 990 Schedule H. We have 8 different items. In combination, they show us community benefits. So we ask question, number one, do they reflect community contributions from hospitals to the same extent? Number two, do they include or are they exhaustive? So 1 and 2 kind of talk about the congruence issue. Number 3, are they within a hospital's control? So question 3 is about sensitivity. So number 1, if you look at the 8 different measures, we can tell some of them are about the charitable mission, right? Charitable mission. For example, mean tested, financial assistance, or charity care. So I always call A charity care. Right? And then you have educational purpose. And then you have scientific purpose, like the research side. So they measure different attributes. Even within charitable mission, let's look at number A, B, and C. Number A, financial assistance at a cost. This is charity care at a cost. Hospitals determine their own financial assistance policy. And then they identify patients who are eligible for that. And then they write off the part or completely the balance of the medical bill. But in B or C, the Medicaid cost or the other mean tested government programs, we look at the gap between the cost incurred by the hospital and the payment received from the government programs. This is actually underpayment or under reimbursement, right? So do you think A and B or C measure the same thing or reflect hospitals' voluntary mission to advance charitable missions same? I would say probably a little bit different. So number 2, do all these 8 things include aspects of community contribution? So in total. we talk about social determinants, right? So if I'm doing many things to improve school-based programs, doing community partnership, or improving housing, let's say I put, smoke detector in all the low-income households, or I improve opportunities for the people usually can, very hard to find a job. So those things are improving social determinants, but they are excluded. They are excluded from those 8 parts. They have a different sector. It's called community building activities. And any money you spend on those community building activities are not included in community benefits. So number 3, so are they within hospital's control? I will focus on part A and B and C. If you are in a state with Medicaid expansion, can I compare you with another hospital in different states without Medicaid expansion? So probably the pressure is different, right, between the 2 hospitals. And also, different states reimburse hospitals at a very different rates. The Medicaid rate different, the mean tested programs have different rates. So I would say B and C kind of out of control, right? But for A, remember hospitals design their own charitable care policy, and then they identify, and then they decide, should we do partial write-off or should we do 100% write-off? So hospitals do have, relatively speaking, the largest extent of control over Part A. So I would say, if you look at the 3 questions, both the congruence and the sensitivity do vary across those different 8 measures. And also we have an incomplete measurement problem. So this is what I call the broad the approach. Let's look at the narrow, traditional approach. So we only focus on charity care, nothing else. So we look at A. So charity care out of cost is measured by, the slide's a little bit off, but it's just measured by the total charge and then multiplied by the cost to charge ratio to convert the contribution to cost. It has high congruence, do you agree? Right, high congruence. If we focus on the charitable mission of the hospital, yes, so this measure aligned with the voluntary charitable motives of the hospital. So do we have a high sensitivity? Yes, because relatively speaking, hospitals do have the highest level of control over charity care. But we still have a problem, even just when we only focus on charity care. So that is, we have very different missions, right, across hospitals. For nonprofit, at least on paper, according to the previous discussion, we are trying to advance charitable mission to justify the tax-exempt status. We are not paying sales tax, income tax, or property tax, right? This is justification. So for-profits, the mission is to maximize shareholders' wealth, right? So they pay tax. There's no tax benefit to them. Then we have public hospitals. Their job is to provide a safety net to the financially disadvantaged patients, and they get funding from taxpayers. So they don't need to worry about the revenue side. So these hospitals have a very different financial structure, very different financing sources, and they have very different missions. So the question is, can one metric or set of metrics be used to measure all these hospitals? So overall, I think it's a great move to measure equity across hospitals. But we must acknowledge the limitation of those measures and try to improve the overall measurement quality. Thank you very much.
Thank you very much. And I think this is about maybe 3 years ago, Agarwal just became the CEO of National Quality Forum, and I give you the keynote speech. And I'm from Brooklyn, and I'm a surgeon, so I have an aggressive personality. So I ran into Ben at the end of the conference and asked Ben, why do US report always give credit to sick care the hospital provider? Why can't we rank hospital based on real health? Right? That was a discussion. So sometimes you are careful what you wish for because it's coming true. now we have a problem. How do you figure out how do you get these metrics right? So the first point is I want to talk about, what I'm going to talk about is, the first thing in the metric is let us not do what we've done all the time. We always measure how well we do. Let's measure how well they got. So let's have this principle first straight on that, right? Because why it's important, because US Health World report comes out. I've been in the healthcare field over 40 years. About 50 data scientists start working on the data just to get the ranking up in every hospital system. So we actually have the people coming in. We hire people who said, okay, please work on that. Please work on cardiology. Please work on this as a part of it. So you have a huge influence on what you do with that, right? So having worked in the public systems, and as well as right now in the Northwell, which is the largest not-for-profit in New York City with over $12 billion, with about 26 hospitals, with 1,000 clinics all over the place, I've always worried about the quality metrics because, as Bruce was there, I was running 2 large public systems in my life past. And always I found out that the quality metrics or the public systems were always low, right, compared to that. The reason I couldn't figure it out in 2000, 2001, 5, then I figured out that the research came out that 80% of the outcomes are not dependent on the clinical care we give. It depends on social determinants. It somehow happened the public hospital system in the country, which I headed, had more social determinants, has got problems. So we are not able to get the outcomes which rich, powerful hospitals be able to do that because they choose the population they want to serve. I always used to say, I don't have a choice of population I serve. They were brought to me at some level. So the same thing, we understood how much social determinants make the outcomes, even the patient outcomes different. So we need to keep that in mind as we are going about and doing these metrics as a part of that. So how do I know that? Because in New York, in Northwell, we assess every patient by a 15-question questionnaire, which is geographically based, depending on the geography they come from. Because if you're in New York City, transportation is not a big deal, but homelessness is a big deal. But if you're in Nassau County, transportation is a big problem, homelessness is not a big problem. So the social determinants change by geography. So we crafted 15 questions based on questionnaire, and every one of my patients have got a social risk index. When I start taking the social risk index and looking at the outcomes, enormous correlation, right? For example, the commonest cause in Queens and Nassau County for the readmissions or 30-day readmission is transportation. The people do not go to the doctor because of lack of transportation, and then they end up in the emergency department. That's one of the major issues with that. So we have to really use this data very carefully and be able to deal with it. So having said that, let me just comment on the 3 metrics we got, right? The first one is easy one to take because it's a community benefit dollars. It's reported. My predecessor eloquently talked about how the charity care is devised by the hospitals and figure out. I just want to add 2 more aspects to it. In that form, we also report medical education's community benefit. But I just want to let you know, I get paid for medical education in a different way. I get GME and IME dollars. The federal government pays me more than what I spend on my residents every year through the graduate medical education, Medicare fund and IME funding. So that's not charity. Actually, I'm making money on that. But I claim it as charity. So we got to be careful. The second thing is research as a charity. As far as I know, for all the things I worked on, every research I had, they were all funded by somebody. So I cannot claim research as a charity care when I'm getting funded by somebody else. So we just have to be a little bit more careful on that aspect of it. Now we go to the tougher parts. The outcomes. We looked at the outcomes, which is very eloquently done, which is, by the way, before I go there, I thank you for doing this because this is something, a dream come true for many years. So this is not any kind of comment on that because you have the boldness and the courage to do this, which is absolutely, as I said, it's a dream come true for me because I've been talking about how do we measure health. Because we have to change the healthcare delivery system. We should call them sick care delivery system over a period of time, but we couldn't get into anything. It shouldn't be Northwell Health. It should be Northwell Sick. Right? So it should be it's not, what do you call it, Sutter health, it should be Sutter sick. Right? So because we only take care of sick people. So to be honest with you, that's what we should do. Anyway, so having said that, outcomes based on ethnic and race has got to be a little bit careful, because when I started doing the SVI and applicable to the people, right, we do have, whether you like it or not, we have geographic segregation in this country. We call them ethnic neighborhoods. That's a code word for geographic segregation. There are aspects of the country, every city has got areas where there is a predominantly black population, predominantly Hispanic population, and we kept them over a period of time, right? So once you start, it so happened that those areas where the minority population is there also have a high social risk index. Because the people who are poorer, people who have got public safety issues, Whole Food will not come and put in a shop there. They only have McDonald's will put a shop there. Because that is a model of care which has been there. So sometimes we look at the color and the ethnicity and think that that is because the color ethnicity is actually underlying factor is in those neighborhoods, they have more social issues. They have lack of public safety, lack of transportation, lack of food, right? Lack of economic opportunity. So many things are coming into the picture. So we just have to be a little bit careful of just looking at the skin color, because it somehow happened, because we have segregated, geographic segregation is still a part of the country, right? Because in Chicago, I know, south side of Chicago, mainly black people live, right? In same thing in South Bronx, Hispanics live. Queens, all the Indians live, right? So this is where we had as a part of it. So we just have to be careful not to just look at the ethnicity and then start doing that. You have to really look one step behind and say, what is the social risk index on that? Then you will see a different picture of that. So I just want to caution that. The last one is the access to care and doing that with the ambulatory sensitive conditions. It's a good proxy, but it's not the only proxy. Because our experience showed, which I want to show you, Northwell has got 750 access points, right, in Long Island alone. 2 counties, 750 access points. Same thing happened in Chicago. When I ran Cook County Health System under the Obamacare, before the Obamacare 1115 waiver, I created 275 access points in south side of Chicago alone. The healthcare disparity did not change. The reason I never understood that, because we always thought if you give them enough access, people will get healthier. That is not true, because you can give them access, but they can't reach the access. Because of multiple reasons. One, because they don't speak the language, or they don't have transportation, they don't have the money to buy your medication. Just because you give them an insurance card or give them insurance for everybody, it does not mean they'll get healthy. Because they should know how to use it. They should find the doctor who will take your insurance. You must be able to get to the doctor's appointment, be able to communicate with the doctor in the language you want, and be able to understand the doctor, and the doctor understands your needs and be able to give you advice. And most importantly, you should have money to buy your prescriptions. So it depends on a lot of things. So counting the number of access points and correlating to the ambulatory sensory conditions, right? That's not necessarily is a good proxy, but not the only proxy. We got to be very, very careful about it, because we have 750 ambulatory centers. We still have a problem. So once we started digging down into there, why is that, right? This is the Southside Hospital, which is kind of made famous by the neighborhood. It's called Brentwood. Brentwood is a place where the M13 gang is very prevalent, right? Which is a public safety issue and part of it. And we have a hospital right down there, right? So we looked at the hospital, surrounded by all the dots are really primary access points. Still, the problem continued. Then when we did a little more than that, we found out it comes from 3 different areas, discrete points, like a public housing area where they are. If I can really get access into those public areas, I can eliminate all other access. Everywhere in the Brentwood area, I will still be able to manage a better access. So, taking the access and just corresponding to the ambulatory sensory conditions it is a good proxy, but we have to be a little bit more careful about it. So, in closing, I want to say that it's a great thing. I'm very happy, and I commend U.S. News and World Report for taking this on, and I really putting the emphasis on where the health should be, not the sick care, and we should really go to the next level. But we have to be very careful in choosing the measurements, because your measurements matter a lot. It actually shapes the industry in this country. I can tell you that. Having worked in a public system and before that in a private system, 6 months before U.S. News World Report comes in, we'll have an emergency crisis management meeting. So everybody comes in there and said, get all the data. We get all the young data scientists trying to crush the numbers and figuring out how to do that. And finally, we submit the reports as a part of it. So you have a huge influence. So if you choose the metrics right, and the metrics based on social determinants, social risk index, and if you compare them, we will have a much better, health equity in this country. So, sorry for kind of putting a different twist to that, but what they have done is a phenomenal job. I still want to congratulate and commend them, but we just have to be careful how we measure things. Again, let's not measure how well we do. Let's measure how well they got at the end of the day. Thank you.
Good afternoon, and thank you. I'm Steve Lockhart. I'm the Chief Medical Officer of, I think it's still Sutter Health. I'm going to have to check that when I get back home. I'd like to thank you for the opportunity to share with you over the next few minutes some of our insights, observations around health equity. I'm going to start with a brief acknowledgement and probably embarrassment of Joe Betancourt because we had a couple members of our team do a fellowship with Joe, and then Joe came out and educated us, and particularly our executive leadership and our board, about health equity and where we can and should go with this, and it made a huge difference because, of course, that helped develop our leadership, which then has made this now core to our mission. So when we think about health equity, you'll all be familiar with the 2003 Institute of Medicine report on equal treatment, in which health equity is identified as one of the 6 key pillars of quality. However, the lack of equity was identified as one of the greatest deficiencies in the U.S. healthcare system. And we agree that health equity is an important component of quality, and indeed, because of that, it is core, inextricably linked to our mission, and we believe the mission of all provider organizations. And although there are many societal factors and social determinants involved in these equity gaps, providers cannot be bystanders in this conversation. Indeed, to the extent that we can make a difference, I believe that we're morally obligated to do so. So let me introduce you to, I've introduced myself, I'll introduce Sutter Health. Sutter Health is a not-for-profit integrated healthcare system in Northern California, serving 22 counties and 3.5 million people, about 1 in every 100 Americans. And we do so in a state that boasts some of the greatest diversity in terms of race, language, and ethnicity in the entire country. And we have both urban and rural facilities. We also take care of more uninsured and underinsured than anyone else in Northern California. And the reason I paint that picture is that it gives us an enormous opportunity to be a great learning lab, or to give us the opportunity to understand how to create new care models to advance health equity, to enhance partnerships with community-based organizations, and to promote access to primary care. So that's who we are. Now, when we first started, we felt we needed to understand where we were and where we were going, which means we needed some form of metric to work off of. And so, being a bit of a data science nerd myself, and got together with other members of our team who were similarly nerdy, we used some innovative analytic methods to develop a new metric, which we did not give a new and innovative name. We called it the Health Equity Index. But it's designed to identify and quantify inequities in care. And we first deployed this with ambulatory care-sensitive conditions, which, as you know, are conditions that, by their nature, are such that they should not require treatment in an acute care environment. Therefore, if you consider any kind of encounter in an emergency department or admission to a hospital, that could rightfully be considered an adverse outcome or a treatment failure. And in particular, we looked at asthma, diabetes, heart failure, and chronic obstructive pulmonary disease. And so this health equity index is a summary statistic that represents the average ratio of observed to expected hospital encounters. The observed encounters is just a counting exercise using our electronic health record, whereas the observed values are calculated from population-based data. This includes considering the demographics of the catchment area of the hospital, the prevalence of disease for a given race or ethnic group, the propensity of that group to use the hospital, and the average frequency of that utilization. And then that gives us the health equity index. Now, although I can make the calculations sound very complicated, in fact, the interpretation, as you might imagine, is quite simple. A number of 1 or below for a given race or ethnic group indicates that that group is doing as well or better than could be expected for that group. Whereas numbers above 1 indicate the presence of inequities, and the greater the numbers, the higher the value, indicates a greater degree of inequity. Now, what's also important to note here is that although in many instances you'll see health equity reported particularly by race, as a ratio up to the white population. Blacks are 3.5 times more than whites, et cetera. But we specifically designed this index to have internal normalization. This is not normalizing against the white population, because in Sutter Health we also care for a large number of rural white population that can similarly be disadvantaged. So we did not want to miss the opportunity to be able to identify and assist those patients. So this is kind of what it looks like. This is an example for asthma for our system-wide data. And we present this health equity index on our operational dashboard every month, both as a system summary and also for each particular facility. And then they can drill down. We stratify it by race and ethnicity, but also by age and by sex. So each individual facility can look at their own data. But this is for asthma, and you can see, I'd like to introduce you to Mr. Hodges, the gentleman on the right who's African American. And he's part of a group that has an index of 2.2, much higher than that of his white counterparts, 1.0, Hispanic 1.1, or Asian counterparts of 1.2. So we asked ourselves, what can we do to help Mr. Hodges and others like him who are suffering these inequities? And by using the index, we were able to identify this problem, and then we said, okay, let's drill down to identify, using heat map technology, where we have the highest number and greatest density of our African American patients. And that, not surprisingly, turned out to be the Oakland-Berkeley area of California. And you can see we geocoded the more than 400 patients that we have in that cohort here, and we're able to identify them, to create a program both for and with them by doing interviews, focus groups, and so forth. And we found out that, interestingly enough, although 72% of these patients live within 1 mile of the little white crosses, which are federally qualified health centers in the area, they drove up to 8 miles to come to the 2 big red H's, which are our hospital facilities. So we worked together in partnership with the federally qualified health centers for lifelong medical care. And we created other methodologies to engage our patients, video technology, and home visits, and community health workers, and so forth. And based upon the ideas of access, community partnerships, and disease and medication management, we were able to reduce the numbers of admissions to the emergency department for asthma in our African American population. So we thought that that was a good proof of concept that the index could be used to identify a problem and also be used to help monitor and measure our progress in terms of evaluating programmatic interventions. I liken this to the idea of precision medicine applied to social determinants, right? If you have a cancer with a genetic mutation and you target a drug towards that genetic mutation, that's the most effective drug that you can use. Here we really need to identify and understand what those issues are, and then we can target them. So we thought that the next thing we needed to do was really to go outside of the Sutter system. And we've been opening this up, and anyone in the audience who's interested, please see me afterwards. We'd love to work with you. This is an example of Salinas Valley Memorial, also in California, who heard a talk like this, and their chief medical officer came and said, hey, we have a large Latino population and a lot of diabetes, and we want to do some work on diabetes in our community. So we worked with them, deployed the index, and as Peter Oppenheim, the chief medical officer there, said, this tool allowed them to identify patients at greatest risk of having poor outcomes and thereby better target system resources. They are a system that has, obviously as we all do, but has limited resources, so that they could identify that actually as their young patients, particularly African American and Hispanic, to some degree the white population as well, but they needed to really target young patients in certain areas, certain geographies, certain language needs, as opposed to just doing a broad diabetes program. So they've used this to make these interventions, and we're following closely with them to see how effective they are. So where do we think this can go? Well, first of all, number one, this is our attempt at creating this index. We think it works pretty well, but we also know that the more it's used, the second, third iteration, some very smart people will improve it and make it a bit better than it already is. But here's on the left is an example of one of the things that conceptually we're working on or thinking about, having preliminary conversations with our statewide hospital planning department, or we call it HOSPOD, who has the data that, provided we can work with them, will allow us to actually put dots for every hospital for a given disease, for a given racial or ethnic group, and identify their health equity index for this particular for a particular condition. As I said, we started with ambulatory care sensitive conditions, but it can be used for prenatal birth rates, et cetera. And that will allow us, in my view, to do something I think is very important, which is to identify patterns, be they geographic, economic, environmental, and also opportunities for collaboration and perhaps even joint funding. And of course, the map on the right, which remains blank, is the true dream that we have that at some point we can help to be a part of this conversation to create metrics that can be deployed throughout the country in order to help us address what has been called the most problematic issue for healthcare in this country, which is the lack of health equity. Thank you.
Thank you very much, Steve, and all of the panelists. I have a whole bunch of, my brain is teeming with follow-ups for all of you, but because we'll have the privilege of being able to reach out to you for follow-up later, and I know we have limited time for discussion with the audience, I'd like to encourage people to approach the microphones. We have one at the back, the one here at the front, and please join this conversation. But thank you very much for the panelists, for your discussant role. Any questions from the audience? Otherwise, I'll start to ask mine.
Or any suggestions of metrics we could use, areas where you think we haven't covered in our preliminary analyses. Really, we open it up to you, unless you think this is perfect and you'd like us to publish this tomorrow. So.
Hi, it's Joe Betancourt, Mass General Hospital. So thrilled that this has been taken on. I guess as I hear this presentation, part of what I'm thinking is that your strength is really thinking about kind of the quality chasm Dr. Lockhart mentioned. This idea of equity is a key pillar that perhaps hasn't been measured, certainly hasn't been measured as well as others. And I would, I think, provided a great example of keeping it simple to start. You can't manage what you can't measure. It keeps equity off the radar screen. And I think all metrics are fraught with challenges and difficulties. But ultimately, we report a lot of measures to a lot of places, and simply getting organizations to just begin by stratifying those, it gets us nowhere as close to where Ram wants to get us, and that's the ideal state. But I think by simply putting this on the radar screen in your rankings, and I think we at the IOM, when we released the unequal treatment and sent a letter shortly after trying to prime this pump, we think it would take us a great step in beginning this conversation, centralizing these conversations within Center for Qualities and Safety and our work on community health. But I would encourage to keep it simple out of the box, and I think there's a lot of very basic things that we could do to start that would get this process going, and you could fine tune as you go. And I guess I just had one question for the panelists. I'm very interested in resistance points as we think about this work, clearly understanding where people might push back, and I think from an organizational change management standpoint, that becomes very helpful to understand. So those who've kind of begun the operations of this, curious as your thoughts there.
Thanks, Joe. I think as far as resistance points, I would say probably I'll maybe list them off. I think one maybe I'll call it ignorance. That's not meant to be a malicious comment, but just lack of knowledge around this being an important issue that we sometimes come into contact with. The graphic that you saw showing equality versus equity, that's another one, right, where people will say, well, we treat everybody the same, we don't discriminate, and then my answer is you should, right, depending on what people are bringing to you. And then I think the third point that I think could potentially, it's a watch out for us, is what I kind of alluded to about collaboration versus competition. I think that when we start to we all have like this competitive streak in us that wants to do better than the next, but the way we do better, a perfect example is the maternal morbidity and mortality in California. It's 23.8 maternal deaths per 100,000. In the US, in California, it's 7.7 per 100,000. And that is largely due to the California Maternal Quality Care Collaborative. So it's a collaborative approach to this that has driven that down and made that huge difference. I think that's the approach that we need to think about when it comes to health equity.
Joe, I thank you for your comments, and I am actually not worried about resistance. I am very worried about that they will completely ignore us. So that's, I'm at the present time, people just ignore it. I would rather have resistance, so that means they're at least trying to listen to me. So I will frame the question a little differently. I think we have to really educate a lot of people. At the present time, I don't think it matters to them because you don't get paid on it.
Also, just a quick response, cycle back to the point I made a little while ago that it's not exactly a resistance point, but it's just where might you get more or less resistance. I found it interesting. In my own organization, it's a big integrated health system. It's got a health plan, it's got a medical group, also hospitals. We have a big health and wellness program, community health program. It is not based organizationally in the hospitals. I think I heard from Sutter, you can clarify, it's not based in the hospitals either. And we heard in the session before upstairs very clearly from Intermountain that the things that they're doing, that they talked about dividing the organization. So we take the hospitals and the specialists, we put them over here, and then we take the primary care and the risk-bearing and all the responsibility for population health is over here. It's not with the hospital. So I think one of the questions about resistance point is, first of all, you have to line up the accepted relationships, the accepted lines of accountability so that you have at least minimal resistance. When you start fighting against those recognized lines, I think that's when it's going to be harder.
I'm sorry, I won't take all the air time, but just to respond to that. What we've tried to, you're correct, although what we tried to do, for example, the ambulatory care sensitive conditions, we actually do put that on the hospital dashboard, and understanding that it's ambulatory sensitive conditions, so they would say, well,꯫ We don't do the primary care, we don't keep them out. But what we found is that there are things we can do, the hospitals can do in partnership with, we do have the power to partner with community-based organizations. We have the power to create co-management as far as care management programs or access to electronic health records and those sorts of things. We talked about community benefit dollars, so we're in a Medicaid expansion state, so we don't charity care has virtually disappeared for us because almost everybody's insured. But where we can put the money is, we can put the money into getting an EPIC into the clinics, the FQHCs, so that they can see our records. We can add different care managers. We can do those sorts of things, which then change the hospital statistics. So it's a little bit outside of their walls. We don't do that work well, but we can partner with others to do it, and we can help support funding.
Yeah, it's fine. I just observed that's a little more nuanced and complex than just straight up, straight line accountability and ranking.
No, absolutely is. You're absolutely right.
I thought there was someone behind me. So this is more of just a comment, just something to think about. And Dr. Lockhart, I do appreciate your comments about maternal mortality. In fact, it's the first time I've heard that term, and I've been here 3 days. So I would say that the World Health Organization had said at one point that one of the best barometers for the health of a population is the health of its mothers. And so if we're really going to look, if you really want to take a firm approach, a firm action approach to health equity, if you're not going to include the health of mothers within that, I think that's a huge limitation for your study. And I'll just leave that there, but thank you for your time.
Thank you. Very important.
Yeah, and I would say we definitely recognize that as a limitation, and specifically on the maternal side, we have some things not mentioned in this presentation that are in the pipeline, but if you're interested in that, stay tuned.
Hello, my name is Khaloud Kazuz. I'm from the Henry Ford Health System in Detroit. So thank you all for being here today and for this opportunity. But also I want to compliment you on your causal model diagram and your methodology. If you could just give us some more details on that. It's clear, but maybe not as clear as I would like it to be. If you could just give it a little bit more information. And then also, do you think it's possible in the future that you could provide us with a little bit more information about the raw data that you pull that, you know, for example, now with CMS, we can replicate, you know, whatever they send us and...
Why don't we talk offline about that, since it sounds like it's about the acute care rankings? Is that right?
No, just...
Are you talking about health equity or our published rankings?
Just in the rankings, okay, or any, like say...
Sure, I think
the ratios.
We'd be happy to talk with you afterward.
And,
if you don't
yep,
mind, but just
sure.
It's a slightly different topic.
Okay.
Thank you.
Mm-hmm.
Hi, Anne-Marie Green from Barnes Jewish in St. Louis. Not that I'm a proponent of this, but you know, more recently there's been ICD-10 codes identified that are trying to get at the social determinants of health. What is your consideration in using those in the future? Again, know that they have limitations, but interested in your thoughts.
Are you referring to the Z codes?
Yeah.
So we have heard about that from a lot of people. So we haven't really looked at how prevalent they are in our data, but we have heard that they're not, because they are so new, they haven't been accurately coded, or the uptake of the coding isn't quite there yet. It is, though, an area that we do want to look in our data for and just confirm what we've heard from others about. But if you all start coding it more accurately, then we can use it.
I think that's a very good point, because Z code, though it is an option in your ICD-10, it is not used because you are not getting paid based on that. So nobody's using it. So once we don't use it, then they will not be able to extract the data from it. So that is why we are kind of proposing to Congress that they should really start paying not on CMI, Clinical Risk Index, they should also pay on Social Risk Index, the one we developed, but that may not be the only thing. A lot of people have got it. Northwell, we have our own Social Risk Index based on these 15 questions. Every patient has got a social index, and we have shown by our own internal research that it makes a difference. Both people, CMI being the same, a higher social risk index actually has a worst outcome, and cost is up, and they're not able to do that. So that is a point we have to really get that into the day-to-day operations to do that.
John Shaw from Next Wave. One of the things that we saw examples of is looking at geography in the drill down and the impact of place, and your zip code tells more about your health than anything. I know that it's difficult to get precise data for individual patients, but you can get at the hospital level the mix of zip codes for each hospital in the country. So might I suggest that they put that under consideration? It's at least more precise than dual eligible that has huge differences from state to state, but you can at least tap that into all of the indicators that are in census and so on in the meantime, until we are able to get good, accurate Z codes at the individual level.
Thank you.
So hi, my name is Fred. One of the things that Dr. Nez said, which I think was kind of interesting contrast between what Dr. Arjun and Dr. Lockhart said was, hey, there's this public health effort, and are you really wanting to constrain the hospitals for these problems, and how do you do it? I've looked at safety net and social determinants data for a long time, and what I see very frequently are these lines where there's some organizations and nonprofits that are concerned about food, some about vehicle security, and those are totally different from the nonprofits that care about hospitals. And all of the interesting stuff is happening at the ridges, and this Form 990 stuff, hospitals tend to look very insularly about, here's what we're going to own, and we're not going to think about anything else. But all of the benefits are at the edges. So you said, should we be holding these people accountable? But in both of your examples, you talked about how figuring out how to incorporate where things were happening and coordinating with, in your case, FQHCs in the various locations was critical. How can you, US News, start to measure that handoffness? Because it seems like it's the critical component of not putting people in a position where they're being held accountable for things they can't control, and also what you have found to work.
So we have done some work on that. New York State has been a lucky one to get a 1115 waiver called DISRIP. We got $8 billion invested in that to develop community-based organizations and collaboration. So Northwell has got like 175 community-based organizations collaborating with us. So what we do is, this is the way it works. We have a SVI, Social Vulnerability Index, on every patient. They come in, they say the high-risk score, they click on that. It tells you why they are high score, food insecurity, whatever it is. Then there is a program called NowPow, which is a proprietary program which we bought, which we are using. It basically matches a patient's zip code to a services. In other words, if you identify food insecurity by zip code, it gives you to either a CBO or a government agency or a philanthropic agency or a not-for-profit or community-based organizations. That gets incorporated in the EMR. So they go to the particular agency and they get back into the system, EMR, and then over a period of time you see these risk scores keep dropping because you're addressing some of the issues. Some of them could be easily addressed. Food insecurity, fine, because we have an organization called God's Love We Deliver. We basically give them medically tailored food in their home, right? I can take care of that. But I cannot take care of housing, which is a bigger issue, right? So we have started doing that. So we are basically not only identifying it, using a program resource guide, appropriately refer them, and whatever they do, it gets incorporated back into the EMR, and then when a patient comes back, I know this patient is actually seen by these through community-based organizations, and they are working on it.
That's a great model that you have at Northwell. That's a great model.
I just want to clarify that if a performance measure has a high noise, or we say low sensitivity, does not mean we should not use it at all. We should still use it as long as it has additional or incremental information content. As when we look at the existing metrics, as long as we have additional information content, we add it. But we have to make sure the weight must be limited. We want to put the heaviest weight, the largest weight, on the things we can measure when hospitals have control. And we have the least weight for the measures that are kind of out of control of hospitals.
And I just, the word partnership is important in this discussion, and I certainly have no problem expecting hospitals to be good partners and collaborators with community organizations. Like everything, though, measurement is complicated, and part of it is when you think about, well, let's measure collaboration, let's measure partnership, sort of the unstated assumption is that the ability or the existence of partnering organizations is constant everywhere, and so what you're really measuring is how well hospitals are doing it. But it's not constant everywhere. There are communities that have rich resources, and there are communities that do not have rich resources. So when you measure, there's going to have to be then some sort of adjustment for who's available to partner with. How easy is it? How well does it work? Do they even exist? So I'm really happy to explore going down that path, but I can already see what some of the roadblocks are going to be going down that path. We'll just see if we could work around them. But just the caution is that partnering in one community is not the same level of difficulty or ultimate success as partnering in another community.
We have time for one more question, but just a thought on that. Perhaps we could even use IRS data on tax-exempt organizations to understand what resources other than health systems are available.
Well, I mean,
in some
for
of these
example, just
communities.
a concrete example, Denver Health has been held up as an example since the start of the hospital readmission program as an example of a good performer. Okay, but it's surrounded by really strong, wonderful community health centers. Now, not everybody has that. So, I mean, you can partner with them. That's great if they're there. But then what if they're not there? Well, then what do you do?
By the way, just a brief comment on that, because I talked about that program in Oakland, Berkeley, city resources that you mentioned. I think about our Lake County Hospital in Lakeside, which is rural. It's got the worst outcome statistics in the state of California. It's very rural, very poor. There's nothing up there except our hospital. That's it. So, it's not much we can do.
Hi, Ann Bob, Northwestern Medicine in Chicago. So I have a question and then a comment to build off some of the other comments. So my question is to U.S. News, are you considering building this into best hospitals, or are you considering this to be a completely separate ranking? And my reason for this question is that I agree completely with Dr. Lockhart's comments that we want to build collaboration around fixing this problem, not competition. And from a very competitive marketplace like Chicago, where our community benefit is finally pulling hospitals together and actually contributing to the community health where they can actually help in the communities, I don't want to destroy that by competing with our very local competitors.
Thank you for that comment. That's a really important point. I actually had the opportunity to have dinner with the Commissioner of Public Health in Chicago. He was an old friend of mine just a week or two ago, and we spent quite a bit of our dinner talking about that exact point, so thank you. Do you want to speak to how this would fit into or not fit into the rankings we publish now?
Yeah, sure. I think that it's, as we've conceptualized it today, is as a separate ranking because we see it as a separate research question, though I can see like bits or pieces of it being quite relevant to quality of care and patient decision support.
Great. Well, thank you all very much for coming and staying to this point today, and thank you very much to our panel for these ideas.